Right. Good morning, everybody, and thank you for joining us again on our series, a very successful series. What we've put together for you now is a series on poison in the patient or on overdoses, and we're going to have a few lectures over the next couple of weeks that'll take you from the basics up until the more complicated stuff regarding poisoning in patients and patients that you see in your ED with drug overdoses. Dr. Carlin Schwartzberg is emergency physician at Netcare Union Hospital. He's always been willing to assist and train and give good lectures, and you'll remember him from the series on ECGs and cardiac. What we're looking for after this is we're going to be going to a series on blood gas analysis, and then I've just managed to speak to Professor Roger Dickerson, and we're going to introduce the ventilation series. So we're doing a lot of training at 7 o'clock on a Tuesday, every second Tuesday, and it's really amazing to see you all here. Carlin, thank you very much for joining us again, and we're looking forward to one of your good, excellent lectures again. And we do appreciate everything that you put into the trauma division and the emergency division at Netcare. Please go ahead.
Thank you very much. Yeah, it's always a privilege, and I'm glad that we get to talk about tox. It's one of my favorite topics, and we see some almost what we sometimes get irritated with, mediocre overdoses in inverted commas, but I think it's really an important topic, and it is something one of our passions because it is really rewarding. So today we're going to go through the basic approach to a poisoned patient, and the whole lecture or discussion is going to be surrounding this mnemonic, the RRSI dead mnemonic. And it's quite a common mnemonic that we do use for this, and it's nice and easy to remember and really gives a stepwise approach. And I like to consider it a bit of a holistic view. And as we go through it, you'll see why I like it so much, and why this is quite an easy way to manage these patients. Again, it's going to be an overview, how to keep the patient going, and the rest of the lecture series is going to go into a little bit more depth with particular topics and particular toxins. So let's start with the resuscitation. So the patient is going to come in, and we often get called to see the patient, and they will and should always be considered a P1, even if at face value things don't seem to be too serious, especially with pediatrics. As we go on, I'm gonna go into that a little bit more. So resuscitation, we always want to put these patients in a resuscitation room, a room where we can monitor these patients, because as they come in, there might not at the time be any obvious signs and symptoms, but these patients can deteriorate quite quickly. So first we're going to go through the basics of resuscitation in the setting of tox, and we're going to start with the airway. Patients that come in that need intubation, whether it be an organophos where there's copious amounts of secretions, where they're going into respiratory failure, patients with opioid overdoses who aren't currently breathing, we don't always want to just rush in and stick a tube down these patients. I always like to say that a patient doesn't die from lack of intubation, they die from lack of ventilation and maintaining an airway. And often as we're getting these patients settled, we're taking handover, there's many basic maneuvers that we can do to keep the airway open. And I think it's always good to stick to the basics, whether it's a jaw thrust, suctioning, an oropharyngeal airway, turning them on their sides, whatever we need to do to temporize until we can make a decision and a proper assessment whether these patients need a definitive airway. Also, often we get patients that come in with a benzo overdose, they might be a little bit somnolent. It's not always fair either for these patients just to shove a tube down them, because they're going to wake up now. So if we can, again, just keep our heads about us, slow everything down, and just do basic things, these airways can be quite easy to manage. Breathing is one of the important things when it comes to the initial resuscitation of a tox patient. And there's a few issues surrounding this, and it's just some things I want to highlight with the breathing, and that's when we talk about assisting our patients through a bag mask valve. Well, a few things I want to highlight there is there are certain toxins where before we intubate a patient, and part of the resuscitation is hyperventilation. So there are four main times that we're going to hyperventilate, and I'm going to explain that in a second as well. Our patients that come in with ethylene glycol, methanol, so our toxic alcohols, our salicylates, and our tricyclics, these patients go into a acidosis. And because they're going into a metabolic acidosis, they start to compensate by trying to drop their carbon dioxide levels by hyperventilating. What we sometimes do is when we do try and take over the airway, we intubate them and paralyze them, which drives up their CO2. And just those few seconds or 60 to 120 seconds that it takes to intubate them and put them on a ventilator can spell disaster for these patients. Why is that? Because they are dependent on their low CO2. So in those particular patients, we need to always pay attention that we need to continue to hyperventilate them before we intubate them. We want to keep those CO2 levels really low as possible. And as well as what a nice tip is, see what their baseline respiratory rate is at the time. Match that with your BVM, and then before you intubate them, set your ventilator to that rate. And traditionally with a trauma patient or whatever, we set it to between 16 and 20 breaths per minute. In these patients, don't be afraid to go high, 30 to 40, because we want to maintain their CO2. And again, it just comes back to the airway. We don't need to rush that airway. Let's get them settled first and bring their CO2 down. Something that works quite nicely is patients with opioid overdoses. They're coming in with they get a high CO2 because they are so respiratory depressed. And if we are going to give naloxone to these patients, again, start to hyperventilate them because their CO2 is building, and that's going to cause an acidosis in itself. So for toxic alcohols, aspirin overdoses or salicylate overdoses, and tricyclics, hyperventilate to keep the CO2 down, and in a opioid, hyperventilate to also drop their baseline CO2. Now, when it comes to the circulation part of these patients, there's a few things that we need to, again, in the acute resuscitation phase, we want to focus on. And again, a tip or trick there is with our organophosphates, always remember, consider these patients as losing fluid everywhere. They're going to be vomiting, they're going to have hypersecretions, they're going to have diarrheas. Our normal dumbbells mnemonic that we use for those patients, they're going to be very far behind on fluids. So start giving those patients a decent amount of fluid and a decent fluid bolus again before we want to put them on a ventilator. We want to give them or back up their reserve a little bit, because by the time these patients get there, we don't know how long they've been down before the families have found them, before the pre-hospital team has been able to get them to us. Support them a little bit, increase the intravascular volume with those patients. Something important when it comes to the circulation side is arrhythmias. And patients that we commonly see in arrhythmias are your amphetamines, methamphetamines, and cocaine overdoses. These patients can come in refractory dysrhythmia, so especially a VTAC. And these patients can be very difficult to get out of. As with trauma, and in tox, I like to say that we start with the circulation often before we go on to the other aspects, because if a patient is coming in a dysrhythmia, trying to intubate them or get focused on the airway, we're going to start causing problems when it comes to the rest of, or when it comes to their circulation. These patients need cardioversion. Most of the time, hopefully, we'll have a pulse, which means we don't need to defibrillate them. We want to cardiovert them. And synchronized cardioversion is something to always pay attention to. Again, when the resuscitation room is frantic and we're trying to get these patients sorted out, focus on, or just take a deep breath and remember we need to do this in synchrony. One of the things that we often see, though, is that because these patients go into refractory dysrhythmias, that cardioversion alone does not help. And that's when we need to start thinking a little bit further and going on to what other, because it's a toxin, what other medications can we use to get them out of these rhythms? Magnesium or, excuse me, calcium is something to always consider. But what we do find is that lignocaine is a really good adjunct to help them get out of these, especially when it comes to your, we'll call them street drugs or illicit drugs. They do impact on the sodium channels often, as well as your alpha and beta receptors, and that's where lignocaine, being an alpha antagonist, is going to help us get these patients out of dysrhythmias. Then we want to come to disability, and these are patients that may be seizing. So again, we see it in our organophosphate patients. We can see it also in our illicit drug patients. And trying to get the seizures to stop is also one of the things we need to do quite rapidly. And checking their glucose is something important. We don't know, always have a history at the onset, what they have taken. Glucose is often a big culprit in these tox patients that we need to correct and then to abort the seizures. I'll chat about benzos a little bit later and how we're going to use them to control our patients. So our next thing, we've now been able to set our patients just on resuscitation. As much as our patients at the time of coming in, the bulk of our patients don't need active resuscitation efforts. But again, we don't know when they're going to turn. We don't know what is on board, and we don't know how long we've got until they start to decompensate. So that's when the risk assessment is quite important. We need to get a history. Hopefully there's some family, or we need to, again, with all our resuscitations, just take that pause and a proper handover from our pre-hospital team, try and elicit as much information as we can get. One of the big things we want to find out is time. What time was the patient found down? What time were they, do we presume or assume that they took the toxin, or ask the patient? Many patients that come in, they're still able to talk, they're still able to respond to us. And I don't like the term at all, parasuicide. These patients that come in, and often, we can sometimes get a little bit irritated, would be, your high school patient that comes in. They've had a fight with their significant other or with their parents. They're stressed about exams, and they come in, and then they have the handover, or you get called, please see a parasuicide. And I think that's very it kind of puts everyone in a bit of a mood. They don't take the patient as seriously as they should. And I don't like that term, because we don't know the reason that this patient has done this. Whether they took 2 Panado, whether they've taken something massive that's still going to have an onset, that term kind of makes us not pay as much attention to the patient. And as we're going to go on a little bit later as well, part of the risk assessment and part of our managing the patient holistically is finding out why this has happened. Is it cry for help? Is there something going on at home that we can also help this patient with? There's a parasuicide. Let's not do that. We don't know exactly what's going on. So get as much information as we can about the patients and try and figure out what dosage they've taken. Part of our risk assessment is to see, what are we in for? We're trying to predict what is going to happen. Again, our patient may be very stable at the time, but we don't know what they're going to look like in a couple of hours' time, or when it comes to paracetamol in a few days' time. So always refer to, I'm not going to sit and give specific dosages because we're going to forget them, and it's always handy just to look them up, but try and figure out how much exactly they've taken. What is their risk of decompensating? How many tricyclic tablets did they take? How many paracetamol tablets did they take? And once you've calculated how much they've taken, we know and can anticipate what is going to go on further. When it comes to pediatrics, the reason there's the 2 tablets there is we often refer to it as the list of 2 pills that can kill. And in a 10-kilogram toddler, there's a list of 13 different medications, and I'm not going to go through them all now. I'll send out adjuncts after this. And just knowing those lists and anticipating, the toddlers running around and took 2 of Granny's beta blockers, we might be in for a bit of trouble. So risk assessment is just trying to get as much detail as we can. Our next aspect is now supportive care. We've managed to either resuscitate or resuscitation efforts on our patient that is in a severe life-threatening situation, or even in our patients, again, that we are anticipating what is going to happen. And with supportive care, a nice way to remember it is using fast hugs, bed pneumonic, which is a very thing that we do with any patient that we have now placed on a ventilator or, well, resuscitating or having resuscitated or going to ICU. And that's just keeping with the traditional things. Focus on all the systems there. We want to make sure they are getting enough fluids. We want to make sure that their glucose is well controlled. Are they well analgesed? Are they well sedated? Are they breathing the way they should? Again, on that breathing is pay attention to symptoms. Our patients with opioid overdoses, our patients with organophosphates, they are going to be filling their lungs with fluid, and we need to make sure we are not fighting ourselves there in the sense that we need to keep suctioning, keep a close eye on exactly what's happening there. Watch your ventilator, see for increased pressures, because we always need to keep trying to stay ahead of the game. We want to put in a catheter always. We want to see what's going on with the urine output. That's going to help us to assess how our fluid status is going. And one important aspect, and we'll get to that, is the nasogastric tube. Keeping them warm. Many of our patients may have overdosed and they might have been on the street for the evening. They might be cold, lying on the floor. Make sure we are warming them. And right at the bottom, there's the psychological. That is really important. Again, whether the patient is on a ventilator and we need to support the family or those who are around the patient, it's not uncommon to even see other patients from homes that are either accidentally overdose or intentionally overdose. And for the patient, like I said, we don't want to be dismissive of any patient who comes in, even if, like as mentioned, they've just taken Tupanol and we think, ah, what are we doing here? There's a reason. We need to pay attention to exactly what is happening in this patient's life and how can we help them going forward, because this might be the triggering event or the kind of warning sign, and then we dismiss them and they come back later with an even worse attempt at self-harm. So we move on to investigations, and there's a little bit of controversy, and we're going to discuss that. But I like to keep things simple. The big things with investigations or with these tox patients is that many of the toxidromes we can diagnose clinically. With a good history, examining our patient well as then just very few bedside investigations, we can get to the diagnosis and manage these patients really well without wasting too much time waiting for results. One of the big things we want to do is, or the first things we want to do is we want to get an ECG. ECG is going to be give us the diagnosis, like the one on the screen, which is worth the classic. Going to give us an output. It's going to be a broad complex tachycardia. We're going to see in AVR, it's going to give us the answer there. So again, then we know exactly where to start treating patients. Many patients might have all sorts of things on board, and it can also, keeping them on monitors and watching their ECG can also give us a heads up of what is going to come. Glucose has been mentioned. This is important. We need to keep watching this, especially in patients that might have taken anti-diabetic medication, patients that took beta blockers or calcium channel blockers. Our glucose is something we need to definitely keep an eye on, and a blood gas. Again, blood gas is going to help us decide or give us clues into what can be on board. Paying attention to the anion gap is really important here. Initially, we might not see too much going on with the acid-base balance, but keeping a close eye, as I've mentioned now, on the anion gap is going to help us either make the diagnosis or rule out certain toxins. One thing we also want to do with investigations is the paracetamol level, and it's something we often see that is done wrong. And there we are wasting a little bit of time, we're wasting a little bit of effort, or confusing the whole process. Is we take a pop screen and we ask for paracetamol levels as soon as the patient comes in. If we haven't taken a good history, we're going to miss the window when it comes to paracetamol. We're going to take that paracetamol level too early. So we know we want to take that level 4 hours post ingestion. What I do see happening is because it's taken too early, patient goes to high care or ICU, and people don't really repeat that level. And then again, as I've said, we might miss the boat. Paracetamol is so common and it's in so many medications that we sometimes do forget about it because we're getting focused on the metformin overdose that the patient's taken. We don't realize they've also taken some or taken a decent amount of paracetamol, and we're going to run into trouble there. Often our patients do leave our unit before the 4 hours. They get admission, they go to ICU, but we need to make a note and then phone the physician that's helping us, or even go up ourselves and say, now is the time when the paracetamol level needs to be done. As mentioned, there's a little bit of controversy when it comes to doing a tox screen. So we can do urine tox at the bedside. Sometimes the overdose is not, they haven't started excreting the drug yet. It's causing all sorts of systemic problems, but we're going to then miss something in the urine. Or even taking the blood levels or the blood screen there, it takes hours and hours to get a result, and we can't sit around and just wait for that. So that's why we need to treat toxic drones. We need to do a good examination and history so that we aren't surprised by anything we find on that. There are also a lot of false negatives and false positives when it comes to urine tox, and there's a multitude of medications, that chronic medications that patients may be on, that can come up as false positives on the urine tox. So don't just rely on those. Okay, decontamination. We need to start outside of the unit. We often or have seen patients that come in, they may be working in the field at the time, and I want to call it the organophosphate plane comes over. They are spraying the fields, and workers that may be in the field might be getting or might get the organophosphate on them. What happens is the patient gets rushed into the ED, everyone starts to undress these patients, and if we haven't kept our staff safe, making sure everyone has their proper PPE on, there can be organophosphates on the clothes or on the skin of these patients. And then we can start to contaminate ourselves or our staff, and then we're in for problems. So we need to consider decontaminating patients, again, taking a good handover outside of the ED. We need to make sure our EDs have working decontamination areas, areas to hose down patients. Something we don't see too often, we see them more in the outskirts, is radiation. So we have seen patients where they are, for example, doing geological surveys, and they use X-ray machines, and those X-ray machines either leak or there have been explosions, and the patient comes in as a polytrauma, but we sometimes can forget that there's been a radiation leak, and we need to decontaminate these patients before we come in, not only for the patient's sake, but also, as I've mentioned, for our staff. So that's an ice cream. It's an activated charcoal ice cream, and I'm going to explain why we've used that. But there are a few different methods to decontaminate patients. So we've now discussed decontaminating them from the outside. Now we're going to start working on the inside. Activated charcoal is often used to bind whatever toxin has been orally ingested. Now there are few toxins that will not bind, and these are our heavy metals, our toxic alcohols, as well as our corrosive, so strong alkalis and strong acids. Again, taking a history, then we know we're going to be wasting our time with the activated charcoal. Most other toxins or Oral medications will bind to the charcoal. And again, taking a history, if it's been more than 60 to 120 minutes, there may not be much value in giving a patient activated charcoal unless they have slow release or extended release enteric-coated medication that is in. The problem with activated charcoal is it's terrible. It causes a mess. The patients do not like it. And so they, especially with children, so that's why, many places they mix it with some ice cream just to get it down the patient. But often we see it just gets mixed with some water and we ask the patient to drink it. And that's not so nice for the patient. They really don't enjoy it. And the problem is they can induce vomiting. So now you've got this black charcoal all over the patient, all over the bedding, all over the floor, all over the staff. And we haven't really done much value but make our patient vomit. So we want to be very cautious with our activated charcoal. So the next thing is, how are we going to decontaminate our patient? Gastric lavage is something that we used to do quite commonly, and it's not really worth doing because of the following. So the one is placing an NG tube in a patient. The danger here is if a patient is not GCS 15 out of 15, if they're anything less than that, we need to consider, do we need to intubate this patient to place the nasogastric tube? Why? Because if a patient isn't maintaining their own airway well, if they're a little bit confused and we start to put a tube down, we're going to induce emesis, and that's an aspiration risk for our patients. So if we have a borderline patient in the sense that the GCS is between 10 and 14, we can make a call there and say, right, we are going to intubate this patient for the purpose of decontamination, even if they do not have an airway issue. If a patient is cooperative and they have a GCS of 15 and they are able to tolerate an NG tube, that is first prize. But anything less, we need to weigh up the risk and benefit with, do we place the NG tube or do we intubate them in order to do that? The reason we want to put in an NG tube is, as I said, we used to do gastric lavage, and not only is it a risk to put in the NG tube, many of the medications that patients might take are not going to fit. The effluent is not going to fit through the NG tube. So putting them on suction or trying to irrigate the bowel is just going to cause logistical issues, and we're not going to get much benefit from there because we're not actually going to get out the toxin or the medication that has been in. The next thing we can consider is when placing an NG tube, whether the patient is intubated and ventilated or cooperative enough, is whole bowel irrigation. So there are toxins that do delay iron, for example. Always mention slow release or extended release medications, especially our anti-diabetic and our beta blocker and calcium channel blockers. We can then do whole bowel irrigation, which is, we can either give it to the patient to drink or we can put it down the NG tube, and that's going to cause them to start passing the effluent per rectum. Yeah, we're going to just keep giving it until we get a clear effluent. And this is just trying to get the medications out before there is absorption. Again, these are things we need to do, not necessarily on every patient, but with our risk assessment, discussing with your team, chatting to the patient and seeing exactly whether these things are indicated or not. So enhanced elimination, there are times when we want to use sodium bicarb, and that is especially in our tricyclic antidepressants overdoses and our aspirin or our salicylate overdoses. Again, as mentioned earlier, is that these cause a drop in your pH. It causes ionization and it causes an acidosis, and by increasing your pH, we want to go over, our target would be a pH of more than 7.5. By giving them intravenous sodium bicarb, not only does this prevent dysrhythmias in these patients, but it's also going to assist the renal system in enhancing elimination of the toxin so that we don't run into problems a little bit later. Dialysis is the next way to do it, and there are a list of medications or certain medications, especially our heavy metals as well as our toxic alcohols, where the mainstay there is going to be dialysis. So again, with the toxic alcohols, we can give antidotes, but those are just temporizing. We need to get these patients on dialysis as soon as possible to either prevent worsening or to help out the metabolic system. So when it comes to antidotes, there's a list here. There are many medications, many toxins which have antidotes. And trying to remember all of those dosages, those indications can run us into trouble. And that's why I don't want to go into those necessarily, because also we're going to be discussing those in further lectures. But the main ones we need to know, and I want to go through some of these because these are important, are naloxone, which one use in opiate toxicity. One of the misnomers is when it comes to naloxone is all opioid overdoses need to be given naloxone. And we don't always agree with that. Why? Because naloxone has quite a short half-life. So what happens is a patient comes in and they are in respiratory depression. We give them naloxone and they wake up. Now we're happy. We feel like a hero. The patient's awake. The family's happy because their loved one is now responsive, able to talk. And we go into a false sense of security. We walk away, and after 45 minutes or so, once the naloxone starts to wear off, the half-life of the toxin is going to be much longer, and the patient is going to rebound. And if no one is watching that patient, we're placing our patient at risk. So naloxone is helpful pre-hospital and on scene in order to get the patient out of respiratory depression, in order to get them to a treating facility. Sometimes we can use naloxone as a rule out. So a patient comes in with respiratory depression, they may have a toxidrome of naloxone, of an opioid overdose, and we give them the naloxone. And if they wake up, we know what is on board and we know how to manage them further. Sometimes if that doesn't work, again, we can now rule out the possibility of an opiate and start thinking about organophos, or this patient may even have a bleed, which can mimic the toxidrome. What works quite well, and I know they're doing it a lot in Cape Town when it comes to naloxone, especially when there was the surge, when ventilators were short, and it does help sometimes or often as well, is patients that respond well to naloxone. Consider putting them on a naloxone infusion. Obviously, keeping them in a resuscitation setting or an ICU or high care setting, but keeping them on an infusion can help get through the half-life of the toxin, which means we can prevent this patient from needing intubation and ventilation. That really is a helpful way of keeping our patients nice and awake and continuing care with them. Dextrose is also something we need to have on hand, as we've said, when it comes to oral hypoglycemics or insulin overdoses. We want to be on top of their glucose, and we want to be giving them dextrose infusions. We mentioned calcium when it comes to dysrhythmias, but also with hydrofluoric acid and calcium channel blockers. Sodium bicarb, we used to give sodium bicarb to every patient with an acidosis, and not only in tox, but in other conditions, and we don't do that anymore. So sodium bicarb is really helpful and should be kept for our overdose patients. And that's the mainstay of treating tricyclics and sodium channel blockers. Atropine, something we unfortunately are no strangers to when it comes to organophosphate poisoning, is we need to keep a lot of stock. So often we only have the 1 milligram vials. You are able to get 10 milligrams. I've also 10 milligram vials, and sometimes we need to go really high to reverse these patients, and trying to break 100 small little ampules is really stressful for ourselves and our staff. And so trying to also keep higher doses in vials is helpful. The rest of the antidotes, like I said, it's always helpful to call the poison center, get backup, make sure we're giving the correct doses when it comes to antidotes, because antidotes are also not benign. So now when it comes to disposition, and we're going through this quite rapidly, is what do we do with our patients? Traditionally, all patients get admitted with any overdose or any attempt at self-harm or accidental overdose. And we have seen, especially now with all the waves we've been having in COVID, we've become a lot more conscious of our resources. So where do we put our patients? Obviously, if we've had to intubate them, if they've had life threats, if we need them in a high care setting because we anticipate their path of possible deterioration, we need to keep them in high care or ICU. Other patients we can possibly put in a ward, but I just want to go back to the risk assessment. This is where we need to take some time once our patient is stable, cooperative, and we're able to sit down and have a good conversation with them. Do we put them in a ward, or are they at risk of serious attempts at suicide? Because if that's the case, we don't just want to keep them in a ward. We're putting them at risk in the sense of, are they able to have access to other methods of self-harm? And this is where, again, I feel quite strongly about building a rapport with our patients. As much as we may neglect and say, you know what, I've got a full ED, I've got really sick patients, and now you're coming here with your fight that you've had with someone in your family or your partner or whoever it may be, and now you're coming here and you're taking up a resource bed. Approaching a patient with that attitude off the bat is going to get us nowhere. They're not going to trust us. They're not going to divulge further information. So building a good rapport right at the beginning is really part of managing a patient with a toxin, or especially a patient with self-harm. And that gives us a better way of being able to risk assess, which is going to help us know, are we able to send these patients home? Is there support at home? What access do they have at home to anything further? Children who might come in with a toxin of some sort, whether it's a soap that they ingested, whether it is granny's medication. If we have assessed these patients and held on to them long enough to know and be sure that they are not going to decompensate and we are able to send them home, it is worth finding out exactly what is happening in the home. Chatting to the parents, chatting to the caregivers, why did this child or toddler have access to medications or accidentally ingesting these medications? What can we do to help? Are there resources we can give them in terms of making the house or the home or the cupboard more child friendly and keeping them safe? One of the things with disposition as well is there a secure base to follow this patient up? Is there support at home? Are we able to put them in contact, whether it is through our trauma counselors, psychologists, psychiatrists, able to help them? Again, I'm not only talking about our intentional overdose patients, but our patients who may have addictions. So a patient may not intentionally want to self-harm themselves, but they come in with a opioid overdose, a cocaine overdose, whatever it is, chatting to them, finding out what is happening. Is there a true addiction? And how can we help them going forward? Do they need to be admitted to a facility, a rehab facility? Are they able to go home? Is there enough support? Do we need to get their work involved? So disposition is not only admitting a patient, it's considering our resources at our facility, as well as what the patient's preference is, what is the safety net for them. So the approach to the toxicology patients, I think, is quite straightforward, and the simpler we can keep things, the better always. It's better for our cognitive load. It's better for our staffing and for our team that we don't keep things complicated. Going through the stepwise method of managing the tox patient is really going to help keep them alive at the end of the day. And that's what we all hear about, and that's what we want to do. So we want to resuscitate our patients. We want to do that in a systematic approach. We want to be aware of the pearls and the pitfalls, especially when it comes to the breathing of the patients and dysrhythmias. Risk assessment, always getting as much history, as much information as we can. Even if the resuscitation is a little bit of chaos and it takes us a while to get our patients stable, we really need to take time to then step away, even if we need to make some phone calls if the family is not present, just to get as much history about this patient and background as possible, because it is going to help when it comes to is, again, managing our ICU patient, making sure they are comfortable. Supportive care also includes the logical side of the patient. They come in stripped down, they don't have their clothes on, they come in of some sort, getting a and they want to go to the bathroom. We need to make sure that maybe we put someone on. So yeah, supportive care is giving a psychological part, making sure dignity in our patients when they're walking around the ED. Investigations, keep those simple. We don't need to run up major bills for these patients in trying to.
Just like that, they asked me for the tour. Then
which is ECG, a blood glucose, cetamol level, 4 hours. Contamination, always remember.
Sorry to bother, can someone just mute themselves?
I think Saturday we can just do like what we did previous. Just go around and then come back and continue. You go up, when you get to the potholes, you buy. You jump. When you pass the potholes, you already tank. They just want to come back.
Right, so decontamination starts outside of the ED, and always consider the safety of our staff. Enhanced elimination, be cautious of how we are going to do that. Be cautious and judicious when it comes to your activated charcoal. We don't want to induce emesis in these patients. Again, there's also no shame in deciding I'm going to intubate this patient in order to put in an NG tube. And we are able to wake them up later, but the main thing we want to do is get the activated charcoal in there. Antidotes, make sure those 4 or 5 antidotes are always on hand, that you have enough stock of that, because they can be quite, you can deplete your stock quite quickly. Make sure your ED is stocked with that. And when it comes to disposition, just also with the antidotes, make sure you are able to chat to the poison line. If there are certain antidotes you don't commonly keep in the ED or the pharmacy at your particular facility, make sure you know where to get assistance. Make sure we also have good structures in place when it comes to emergency dialysis. Something we have seen is that some EDs, when you speak to the dialysis, they say, look, your taps aren't compatible. Now we're sitting with a problem. So make sure that your ED has taps available or fittings available in order to get dialysis there to the patients. Disposition, I've spoken to quite a few colleagues at different centers, especially around Gauteng at the moment, in both the public sector and the private sector, and there's been a major increase in self-harm attempts, mostly when it comes to or using toxins. A lot of people are burnt out at this time of year. A lot of people are struggling, especially with the multiple surges that everyone has experienced over the last 18 months or so. People are stressed. They are in financial crises. We are seeing a lot more toxicology than we normally do. And again, as I said earlier, this can be a really rewarding aspect of emergency medicine, because we can do so much for the patient, not only when they are coming in extremis and keeping them alive and getting them admitted and eventually seeing them walk out the hospital, but it can also be rewarding in taking time to chat to your patient, taking time to see exactly what's going on, because we can make a major difference in getting them down the right or on the right path in order to help them cope with whatever it is that they're going through. So with Disposition, you know, always put a little bit of thought into it. Don't just throw them in a ward or in a high care or ICU. Consider the resources that you have. Consider what other safety nets we are able to make use of. That is all I wanted to cover in the approach to the tox patient. I have kept a little bit of time aside if there are any questions or any discussion or tips or pitfalls that other people have experienced. Like I said, we've learned quite a lot when it comes to naloxone from our colleagues in the Cape. So yeah, I'd like to just leave a few minutes for questions or comments, please. Okay.
Yeah, it looks like there's no questions.
Okay, good.
Anyone
All
for
right.
comments or anything else?
Okay, good. So we'll keep it nice and short and sweet. And remember, always I like to keep things nice and basic. And so sticking to the principles, and you and your patients are always going to be safe. Just want to thank everyone again for their time. And yeah, feel free to reach out either to myself or any of your colleagues, especially when it comes to talks. We're always happy to be involved.
Cool. Thank you so much for your time. And so the next part, that will be part 2 of toxicology that will be presented by Dr. Victoria Stephen, and that will be on the 9th of November. But I will share the link again. Can I please just ask for attendance registers from the ED managers as well? And then have a good day. Thank you so much for joining. And thank you very much, Dr. Garland. We really enjoyed it.
Pleasure. Thanks so much.
Well, have a good day, everyone. Thank you.